Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insulin.
Hello, I'm Dr. Ann Peters, Professor of Clinical Medicine and Clinical Scholar at the Keck School of Medicine of the University of Southern California in Los Angeles. Welcome to this program titled Expanding Automated Insulin Delivery to Type 2 Diabetes, Where Are We Now? I am joined today by Dr. Eden Miller, in Family Medicine, Diabetes and Obesity Specialist in Bend, Oregon. Welcome, Eden.
Oh, it's a pleasure to be here with you today.
Type 2 management has undergone a paradigm shift during the past decade, with treatment preferences moving toward increased use of non-insulin agents that provide cardiorenal protective benefits. However, many patients will still require insulin to achieve glycemic control and reduce the risk for diabetes-related complications. Diabetes technology in the form of automated insulin delivery systems has evolved to provide better and safer insulin therapy. In this program, Eden and I will discuss the contemporary use of automated insulin delivery systems in the management of people with type 2 diabetes. So, Eden, can you start by talking a little bit about why AID was developed for people with type 2 diabetes?
Yeah, that's such a good question and concept because many of our colleagues, really don't think of AID for those with type 2 diabetes. But the reality is that a person with type 2 diabetes who eventually graduates to insulin, over time they'll graduate to the comprehensive need for insulin in all of its forms, as well as the benefit of pausing insulin or adapting or adjusting insulin. And so I think it's kind of a new concept of that AID, automated insulin delivery, for persons with type 2 diabetes. Now, it is different because many of people with type 2 diabetes kind of wade into the insulin pool, right? A little bit of basal, and then we've got that big inertia of basal plus one mealtime and then advancing to total mealtime. So it really does strike me as a nice concept with people because it can potentially overcome some of that inertia related to insulin administration in persons with type 2 diabetes. When we look at some of the data, especially emerging regarding the kind of proof of concept, right? Pretty much all the pumps that are leading the charge in AID has some kind of data or indication related to type 2 diabetes. And that's kind of comforting, whether they're prospective trials or retrospective analysis. And then we have a lot of chatter about it too, commentaries, this program, to really kind of show our colleagues, hey, technology is a great equalizer. It really can fill in the gaps a lot of time for persons with diabetes. We definitely see the benefit of continuous glucose monitoring. So why not for those individuals the consideration of AID for type 2 diabetes? I think it's an interesting concept, and that's why I really think that having that discussion and that commentary regarding it, and maybe some familiarity as well. So one thing too is, Ann, talk to me a little bit about the standards of care of how they're emerging for looking at AID in people with type 2 diabetes.
Well, certainly the standards of care have evolved because historically we didn't have data that standalone insulin pumps didn't really help people so much with type 2 diabetes, but automated insulin delivery has actually really made a difference. And I loved what you said about that it's a great equalizer because we've now shown in many different settings that if you use these systems, and maybe with a little bit more education in people who don't have that high level of health numeracy, health literacy, that you can get people to target in no matter what the setting. And this is so much easier, if you ask me, than giving injected insulin. This is something that works for patients in all settings. And I love that notion for treating our patients.
Yeah. One thing, too, I'm always reminded is that when you make it in the standards of care, there is a lot of background evidence, as much as I interface with it or I try to translate it. Behind every recommendation is a data trove of indication and level of support. And when we look a little bit closer at AIDs, we know their standard of care with type 1. But what a new concept with type 2 diabetes. And you also bring in the numeracy thing. And even though when you think of it as, well, you have to understand it, but I also want to make sure that we don't have that inertia related to, oh, my patient is too of advanced age, or maybe they don't understand. I often say that diabetes doesn't care if you're smart or dumb or rich or poor. It has its own rules. And yeah, it might be a little bit of a learning curve, but once you're there, those systems are designed to, how shall I say, really filling in the gaps that people often have when it comes to insulin, and especially our type 2 population.
Yeah, no, it's been amazing. Using it in my type 2 patients has really changed my perspective.
Yeah, and it's great for educational opportunity, and it might take some time. I'm sure we'll have early adopters and we'll have some little laggers, but I think it's also going to be good too to start the conversation, right? A job begun is half done when you start talking about it or considering it. One thing that I'm very excited looking forward to is I'm working with the ADA this next weekend at developing workflows for incorporating technology in primary care, and some of that is really understanding if you have a desire to use an AID system, it's really being like, what is the workflow required? And we're trying to make that easier for our colleagues to determine the essential features in order to start adaptation. And so that's why we're having these conversations. One of the very first things I really try to encourage my colleagues to do is understand that clinical inertia is pervasive. We all know clinical inertia on the side of the person with diabetes, but sometimes there's clinical inertia on our side. And there's this little catchphrase a few years back that I coined that said, don't ever let clinical inertia be traced back to you. And it's not that I'm trying to shame or blame or point the finger, but rather I say, wait a minute, am I not providing technology to people because of their age? Do I have a bias on age? Do I have a bias on literacy? Do I have a bias on socioeconomic? Do I have a cultural bias? And we find some of the greatest inertia in type 2 diabetes and insulin, in titration, in advancement, in getting them to target. And so sometimes when, my HCP colleagues say, well, I don't think they benefit from AID technology, I say, well, is what we're doing really working? And a lot of times the answer is no. And so I think maybe looking up, being real with your own barriers and preconceived ideas, and maybe having a little bit of an open mind is maybe half of the battle. And then from there, we're going to say, what kind of workflow do we need to do to make it happen?
No, that's true. I do think, just to defend practitioners a bit, is that for many of us, the burden of prior authorizations and how do we get the pieces to patients is hard. And I don't want to actually promise something to a patient that I can't get for them.
Sure.
And that's why I love that we've been able more and more, because of guidelines, because of evidence that we're going to discuss, become able to get AID systems for people with type 2 diabetes. But you have to be aware as a clinician, I think, of what true options are so we don't disappoint anybody by overpromising. So let's discuss the studies that there have been done, and we're going to do this in sort of subsets. So the first studies I'm going to talk about are the Omnipod 5 studies, and these are called Secure T2D. And we also have real-world data from the Omnipod 5 systems. We have the Tandem Control IQ study, which is called 2IQP. And then we have the MiniMed 780G study, or the Impact 2D, which is both an observational study, and we also have real-world data. So let's start with the Omnipod 5 Secure T2D, which was a single-arm observational study. But this study, as I said, was observational, had 305 participants, and it lasted for 13 weeks. In this study, the average age was 57 years, BMI was 35, so these are the sort of the typical type 2, duration of diabetes 12 years, 28% were considered low income, they made less than $50,000 per year. They did a pretty good job in terms of looking at patients from a mix of different populations. 50% were non-Hispanic white, 24% were Black, and 22% were Hispanic white. And actually, that was my site where our patients were almost entirely Hispanic white. And many had not had this kind of resource before. And in this particular study, 30% were not on CGM coming in. And that was actually, from having done the study, one of the barriers, because people had to get used to everything, and yet it still worked. Patients could come in on MDI, multiple daily insulin injections, or basal insulin alone, plus other type 2 meds. And this is important because this is really the way we treat patients. And 55% were on a GLP-1 receptor agonist and 44% on an SGLT2 inhibitor. So real patients on insulin of one sort or another needing advancement. Baseline A1C was 8.2, and during the 13 weeks of the study, this fell to 7.4%. If you were on basal insulin only, people started higher at 8.6% and fell to 7.5%. And what's important in this and all the studies is response had nothing to do with baseline C-peptide level. We need to change that requirement for using insulin AID therapy and pumps. Time in range increased from 45 to 66% without an increase in hypoglycemia. And in this study, the patient-reported outcomes were, in fact, improved. People didn't mind this. In fact, they liked the technology. The BMI went up a tiny bit by 0.8 kilograms, but the total daily dose of insulin from what was reported at the beginning to what happened at 13 weeks actually declined. And I see that a lot. I've seen people go from what's supposed to be a lot of insulin, like 200 units, down to, say, 60 units. But partly it's because I think people report what they're taking differently than what we actually find out when they're on the system. Then in terms of the real-world outcomes, this was actually an abstract that I presented. This looks at over 400 adults with type 2 diabetes and looks at their time in range, which is what they got from the data they could capture. And what's neat is that in every age group, people had an improvement or had pretty reasonable time in range. But the highest time in range was the seniors, people 65 and greater. And they
with
had a
that
time
lowest
in range.
target, right?
Exactly. Well, everyone got the best with the lowest target.
Yeah.
But the seniors did better. And I have people in their 80s who are really having trouble with multiple daily insulin injections, and I put them on an AID system. And it's amazing. It's easier for them. It's easier for their caregivers. It really changes things. So I don't consider age a barrier here at all. And I do believe that we have to educate and maybe educate more for people who are older. But I think it's incredibly important to know that this can work across the age span in our patients with type 2 diabetes. So further thoughts about this study?
You know, I really had the distinct pleasure of kind of going through some of the real world evidence. And one of the things that really captured the primary care audience was that reduction in the insulin. So, you know, as I posed a question to them, because I think we often see individuals that don't quite report what they're taking because of inertia and lack of transparency. But I also know this, you know, there's still other contributing things to that. A person could take maybe an over-basalization or too much long-acting where it's not really getting therapeutic benefit. We also see that when you're on multiple daily injections, you never can pause the insulin. And so you don't have that pause effect of where that contributes to the reduction in total daily dose. You don't have to feed the beast of hypoglycemia. And you don't always have to have those scheduled meal times, even though we know frequent good meals are good for us. But it really is more of a real world kind of adaptation of the amount of insulin. And then analog insulin is a little bit more pure, right? We get a little bit better pharmacokinetics and dynamics. And so it really, I think for the crowd was like, oh my goodness, these individuals, it might reevaluate our thoughts about people who are on a higher total daily dose, that maybe that it isn't a deal breaker for them. You mentioned the age. I thought it was fascinating to see that they didn't have a higher rate of hypoglycemia at advanced age with a tight target. They actually are a little more consistent, right? And that they saw that improvement in glycemia. I think the thing that really still just fascinates me is this was, a 12-week trial? Think about if we did a chapter 2 and we did additional intervention, but it shows how well and effective it is at the very beginning.
Yes, I had just an amazing response. I had patients who, honestly, they were older, they were from my under-resourced population. They hadn't a lot of training or skill in terms of diabetes management because they didn't have access. And we gave them all this, and they were like,
We're giddy.
I know, but it was unbelievable. And then, of course, we had issues with getting prior auths and things, but we did that too, because after the study, you wanted them to stay on it. Nobody wanted to stop it. It was pretty remarkable. So I learned so much by having done these trials and participated, because I learned about what it is that really makes my patients happy. And that's really what we're all about. Now, let's look at the Tandem study. And Tandem, unlike the Omnipod study, is a tethered pump. So this is a different kind of concept for patients to some degree, but the automation isn't that dissimilar. So this is the only study that was a randomized controlled trial. This is, again, a 13-week trial, similar number of patients, 319, and they were randomized 2 to 1, so 2 on AID to every one who wasn't on AID. And the patients stayed on their pretrial insulin, so they weren't on a pump, they were on their pretrial insulin delivery. This was, again, a high rate of patients on GLP-1 receptor agonists, but between 40 to 52%, and most coming into this trial were already on CGM. To come into the trial, they had to be on multiple daily insulin injections, although that could be just a long-acting basal insulin plus 1 shot of rapid-acting insulin, so it wasn't necessarily full-on 4 shots a day. The average age, very similar to the last, about 58 years. 58% were non-Hispanic white, 21% black, 11% Hispanic white. And then they looked at things like educational achievement. Annual income was similar to the last group. About 25% had a less than $50,000 per year annual income. The majority, 58%, had private health insurance, but it did have a number of people who were not on private health insurance. 18 years diabetes duration, body mass index similar to the other trial of around 34. The baseline A1C started at 8.2% and fell to 7.3%, which was statistically significant. And in the control group, they got somewhat better. They started at 8.1% and got down to 7.7%. That's the clinical trial effect because they were being followed. The time in range increased from 48% to 64%. And this was without any increase in time below range, and it basically didn't change in the control group. And there was a reduction in total daily insulin dose, as with the other group, from 95 to 87 units. So they then did an analysis, which they published, looking at their response in terms of their C-peptide levels. And as the same thing in the Secure T2D trial, there was no relationship between C-peptide level and response. Listen to this, CMS. This is not a requirement for responding to this kind of therapy. So Eden, what did you think about these trial results?
Very much confirmatory. You know, we're seeing alignment in the similarities between the trials, slight different, which is good because then we get different parameters and maybe different backgrounds and demographics, but it also pretty much came to a similar conclusion. The improvement in the time in range, either, you know, pretty similar or lower insulin dosage. We don't see this age limitations related to it. I love the shout out to the no more low C-peptide. I would love to see a lot of those things change. You know, I always feel CMS is so optimistic that every year persons with diabetes are going to get cured and they need to keep proving it. So I would love to see those updates be updated so that way we can remove some of those barriers of acquiring these very, very good AID systems.
Now, in terms of the last system that's been tested, the MiniMed 780G was tested in people with type 2 diabetes in the IMPACT 2D trial. This was another observational study. This is a 13-site, single-arm study, the smallest study, but again, it all kind of blends together because in every one of these studies, the systems work. So this had 95 participants, average age of 60, diabetes duration of 18.6 years, a slightly lower baseline A1C of 7.9%, about the same BMI of 36, mostly non-Hispanic white here, so this was a little bit different that way. And these patients were on basal bolus therapy. They then were on, and it's interesting, they had 21 days on open loop and then 90 days on automated insulin delivery. So it was a different design. And so these people, they sort of learned technology from that open loop phase. When we did the Secure T2D, people kind of some of them, because they never had even been on CGM, jumped into this. So these people had 21 days of learning how to use a pump. But then they were on AID. And when they did this, the A1C fell from 7.9 to 7.2. And the time in range changed from 72% to 80%. So honestly, these people had gotten better a bit from the non-automated insulin delivery phase, and then got further better when automated insulin delivery was provided. There was no increase, same thing, in time below range. And in this case, the insulin dose increased from 77 to 92 units without weight change. But you see, I think that in this trial, because they had them on a pump to start with that wasn't automated, they could count how many units they were giving. In the other trials, we had to say, how many units are you giving before lunch most days? And they would say a number. And it's not that they were lying, it's just that it's really hard to remember and count. So here it was counted and they went up a bit. But it nonetheless showed very similar results. And then because the 780G had been available in Europe for a lot longer than in the US, they had some retrospective real-world data. And the data they had was from over 26,000 users. And these are people who reported that they had type 2 diabetes. And not only do they have all the data, they divided into people who were more resistant and less resistant. And they did this by counting how many units they were on per day. So they looked at those who were on less than 100 units of insulin per day and those who were on greater than or equal to 100 units of insulin per day, as well as self-reported T2D versus not. And basically, it didn't matter. And that's what's cool, is it didn't matter how many units you were on per day, whether you had type 2 or not. The people got better, and they had an improvement in their average time in range. And at the end, the time in range was 72.2% without an increase in time below range. But if the target of 100 was used, and in this system it would go down to a target of 100, they actually improved the time in range to 78.7%, which was cool. They also had an active insulin time of 2 hours there. So at the tightest targets, they did the best without an increase in hypoglycemia. So what do you think about the IMPACT trial?
We're seeing a pattern here, aren't we? And the pattern is also that AID, it's not specific to a particular system, it's specific to the person and that concept of type 2 diabetes. And I think you're also addressing those common things that we think of. Oh, it can't be for people on higher doses. Oh, I don't know about literacy, numeracy, and age related to that. Do they really get better? Are they really improving? And I think also too, you know, this concept of insulin and type 2 diabetes tends to advance over time. You know, when you have type 1, you get kind of thrown into the deep end of the pool, right? You have to do all those things and you have to come to that understanding quickly. But with type 2 diabetes, the insulin needs advance over time, especially with longer living. And what a better way to start insulin administration that can adapt and graduate with an AID system. And so I'm actually looking forward to really the opportunity to introduce this into the primary care realm, to get them comfortable with doing it, because I think it's going to really overcome a lot of barriers and fill in a lot of gaps for those with type 2 diabetes on insulin.
Oh, no, I couldn't agree more, because I don't even know, how many units do I start a patient on before a meal? Okay, well, I'm not going to teach him carb counting right off the bat. That seems like impossible. Okay, well, so take 5 units before breakfast? I don't know. I mean, these
like
systems
spin the wheel,
really
right?
help.
Yeah.
And, what should the basal rate be, and where there should be more or less at night, and whatever's going on. This system makes it so much easier for us.
We're talking about the same AID that we use with type 1s. These are not type 2 specific AIDs.
No,
they're just general AIDs that are also adaptive for the type 2 population. So it's the opportunity to meet the person where they're at in their disease and not be like, oh, you have to have all these prerequisites before an AID would work for you.
And I'm telling you, the easier we can make it early for a patient, the better. I think someone was talking to me the other day about the trauma of their diagnosis. I think being on a system like this takes away a lot of the trauma because it's easier. Let's briefly discuss a case, and I'm going to discuss a case that really sort of gets to my heart. So I take care of a lot of under-resourced patients in East Los Angeles, which is a very poor, primarily Latino part of Los Angeles. And these patients have really hard lives. They have food insecurity, they don't have a lot in the way of steady income, and the challenges of managing their diabetes, particularly when they require insulin, is almost impossible because they have jobs where they don't let them take breaks to look at their blood sugars. They can't bring insulin to work. It's a really tough and difficult place. And so I have a patient who was in her 40s, and she ended up on multiple daily insulin injections and everything else, and is a field worker. And she goes to work and she gets up at 3 in the morning and has to go and pick strawberries or whatever they're picking that particular time of year. And she's supposed to be giving shots. Well, that doesn't work. But you can see she's trying, you know? And she's giving her basal insulin and she's trying. She gives insulin before breakfast when she can, but she doesn't want to go low on the bus, and takes her to the fields, and she then gets home and she eats the most food there if she happens to have food, and she gives her shot. So she never got her A1C down below 8. And carb counting is not something that was easy, but moreover, she didn't really have a kind of diet she could control that well. So we put her on this system, an AID, and a lot of my people who have these jobs in construction or in the fields or whatever, they're afraid, A, that someone might see it. And if somebody sees they have diabetes, they may get fired. And second of all, they don't want it to get caught on things. And so this is, I give everybody the choice. What system do you want? These are the systems you choose. And my bias, by the way, was that it wouldn't work, because I thought that in the heat, and she's out there in the fields, that the thing would sweat off, right? And that it just wouldn't work. Well, you know what? It worked. She worked with my diabetes educator. She found a way to make it stick. She found a way for it to run effectively. And you have no idea how much better she got, because now she could give a dose, and she could give a dose while she was at work. She could give a dose, you know, when she just got home. She could give a dose when she went on the bus. And she actually was able, with the technology, to keep her glucose levels under such amazing control. And for her, I mean, it just made her feel so much better, because nobody wants to feel like a failure, right? And she had felt like a failure on insulin, and she knew she should be on it. And, you know, she was doing everything she could. And now it was working for her. And I was so happy. And I was so happy that it worked in a way. And I'm telling you, there was a certain bias I had that this couldn't work. And yet it did.
When you first introduced that to her, what was her response?
I think that she so much wanted hope. She wanted to know that, first of all, I think everybody likes to know that we care.
Yeah.
And she felt cared about. And we tried for all these years, but, you know, in a busy clinic, and we just said, look, this is an option. You can meet with an educator. You can really learn this. So I think she really jumped at the opportunity to learn. And it really changed things for her. She got an educator along with the device. And I know that, you know, in primary care, I think it does help to have an educator to help with at least the initial setup of the device.
You know, that's one of the things we're kind of looking forward to primary care and recommendations, because each clinic model is a little different. You know, you have kind of your model where you identify the individual, then you get them the resource. You know, there's so many different, there's some that have embedded CDCESs, or they're at different levels, you know, but one of the nice things is that all these companies that provide these AIDs, they will give a pump trainer. And so even though we want the whole team working, and the whole team could be several people or a few people doing many of the team's jobs, right? But we identify individuals, and I think having the conversation, do you think that maybe you would like to try a system that kind of remembers you have diabetes when you want to forget a little bit? And I think identification, as we've gone through today, it's a lot of people with type 2 who could benefit. And then finding who's on your team, you know, whether you refer to a pump educator, or in your case, you have somebody who tags along as a CDCES that you've employed, but there really are multiple team members. And so the steps to incorporating technology are identifying the person that would benefit from technology and AID. And then number 2, how do I get those things? How do I get the pump to be applied? But at the same time, you know, looking at these trials, these were not a lot of high touch in those 12 weeks. And so I don't want our colleagues to think that they're having to, like, you know, follow them continuously. And so this is what's so nice about that is it's just a lot of it is just entry-level pump orders that many of the companies really will walk you through of how to choose those settings. And then just kind of regular CGM follow-up. We should all be learning how to interpret it anyway. So I think it's an opportunity, but look at how adaptive these systems are. And to your patient's point, like, did she find it challenging, or was it more liberating than anything?
It honestly made it so much easier. she didn't have to worry. She didn't have to bring insulin pens around with her. She could just use the system. Now, mind you, you do have to troubleshoot if it doesn't work. But it's easier with type 2s than type 1s because they're not going to go into DKA. I mean, to be fair, it works. And it was just a really nice change for her. But I'm going to tell you, the place where I'm the proudest is at the Venice Family Clinic, which is one of the largest free clinics in the country. And it's all primary care. I've started over 100 patients on AID systems. And once you get through the training phase, they're just like, you kick the tires every 3 months and make sure things are going okay. I mean, it's working. And our A1Cs have come down from, I think the starting A1C that we've been watching, we started at about 8.4, 8.5, and their A1Cs are down on average, out of those 100 people, down to 7. And it's because of the team. So I'm really proud of this because we're able to do it in a much broader way and in primary care. But it takes a team and it takes champions. But I think people need to find or connect with people in their communities and the people from the companies who are willing to help train and help follow patients because that's so important.
Well, I love that you and I have started the conversation regarding AID and type 2 diabetes because I think we're going to have more conversations in the future regarding this.
So, Eden, thank you for this great discussion, and thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.